Good evening, guys. So today we have this interesting session about Cauda Equina syndrome, which is although seemingly a very highly specialized topic, but it's a really important one for every one of us in any specialty, and something that could never be missed or misdiagnosed at all. Our presenter today, Dr. Abdallah Mahgoub, is a specialty doctor of orthopedics, and the mic is yours, Dr. Abdallah. Go on.
Thank you. Just a second. Hello everyone, I'm Abdallah Mahgoub, orthopedic specialty doctor, Lincoln County Hospital, United Lincolnshire Hospital Trust. Actually, my topic today is Cauda Equina syndrome. I think it's a very important topic to be known by everyone work in medicine, as it's highly urgent condition, need to be early recognized. I think should be known by doctor who work in emergency department, medics or GPs. It's very important to know or have some information about this condition. So what's Cauda Equina syndrome? Cauda Equina syndrome is a rare but serious condition that describes extreme pressure and swelling of the nerves at the end of spinal cord. So it's a space-occupying lesion of the nerve roots in the end of the spinal cord. So we are talking about the epidemiology of this condition. It's very rare. It's occur about 3% of all lumbar disc herniation, about 1.5 to 3.4 cases per million, more common in males in their 30s, and mostly common between lumbar 4 and the lumbar 5 disc space. So it's very rare, occurring in male in their 30s between lumbar 4 and lumbar 5. It's the most common space. So as we see here in this picture, this is anatomy of the end of the spinal cord. As we can see here, this is what's called conus medullaris, which is the end of spinal cord. Here, it's terminal end of spinal cord. As we know, the spinal cord is terminated at the lower end of lumbar 1 vertebral body, or between lumbar 1 and lumbar 2. Here's the end of spinal cord. This is area called conus medullaris. And there is a phylum terminale. Phylum terminale is a fibrous extension here from the conus medullaris, this one, to the coccyx. As we see the picture, it's a fibrous area, this fibrous area outside. It's non-neural area at all. Then the Cauda Equina, which called the horse's tail. This is the nerve roots, as we see here, as the spinal cord in between lumbar 1 and lumbar 2, or at the lower end of lumbar 1. After this one, we can see this nerve roots, which called a Cauda Equina or horse tails. It's a collection of lumbar 1 to sacral 5 peripheral nerves with the lumbar canal. Compression here is very serious in this area. And compression here, which will lead to the condition which you are talking about, which is Cauda Equina syndrome. What is the etiology? As we told, this is a compression, or this is space-occupying lesion. Any lesion in this area can lead to this condition. What's the common reason is the central disc herniations. As we told before, usually between lumbar 4 and the lumbar 5, it's the most common site. Spinal tumor, spinal abscesses, meningitis, spinal hematoma or hemorrhage, spinal arteriovenous malformation, spinal trauma lead to some fracture which compress the canal, or dislocation between spine, which called spondylolisthesis, spinal stenosis, spinal anesthesia after spinal anesthesia, any spinal surgery after the surgery, maybe complication is a Cauda Equina or another rheumatological condition as ankylosing spondylitis. So we can know from here that any lesion which compress the nerve roots will lead to this condition. So metastasis also is a cause. I have seen many cases metastasis has some primary origin either way, but metastasis make comparison here at this area. It's very important to know the etiology also for your diagnosis and for investigation that we will request later. So what's the presentation? Patient will come to you, you will ask about the history. Most common, he will have a history of lifting heavy object with lumbar spine flexed position. Also, this is the most common cause, as we told, this is disc herniation. So we will ask about this during the history. Have you have any history of disc prolapse? Have you lifted any heavy object? You can ask about anticoagulant. As we told, this is some collection of blood can make space occupying lesion or can compress the nerve roots. So we can ask the patient, are you on blood thinning medication? Have you any anticoagulant? Do you have any trauma for your back recently? This is some question we will ask during the history. As we saw also, this is one of the etiology of the infection. So you should be sure that this is patient IV drug users or no. And you can ask a patient, do you have any surgery for your spine recently? Ask about these things in spinal anesthesia. This is to know. If you know the etiology, you can ask during the history taking. So history, we are finished. So what's the symptoms? There is some symptoms which is most common, but not most specific for the Cauda Equina. And there is some less common, but more specific for the Cauda Equina. The symptoms is most common with any patient of back pain. He will come complaining from back pain. This can be due to disc prolapse or for muscle spasm. Any patient have this complaint, back pain. So it's the most common, but not specific more for the Cauda Equina syndrome. But this will be the initially presenting symptoms. Maybe unilateral or bilateral leg pain. As we know, the back pain may refer the pain to one of both legs. This is the most common symptoms. This is saddle anesthesia, which is the most specific symptoms, which is very important. If the patient came to you and you ask about the history and symptoms, and he told you that I have numbness or tingling around my private area or genitalia, please, this is a red flag. You should stop and take more details. This is very important. I have seen a patient came here, he's coming walking normally, and the only complaint from him that I'm not happy about my upper thigh and around my private area and genitalia. There is some numbness. I have feeling tingling. So this is a red flag. A bladder dysfunction. This is that we are talking now about saddle anesthesia and bladder dysfunction. It's less common but most specific to the Cauda Equina. The bladder dysfunction. Patient may came with urinary retention, and they may came with overflow incontinence of the urine, because it starts by urinary retention, but eventually can progress to overflow of the incontinence of the urine. So it's very important to document the bladder dysfunction during the examination, as bladder dysfunction may happen after surgery also. So it's very important to document this one. Okay. So unilateral or bilateral sensory changes in the leg, while he said, I'm not feeling my leg well, or there is some weakness in my leg or thigh, or he can told like this. And I have this patient, he just to complain from sexual dysfunction. I have one lady, the main complaint from her that she cannot feeling anything during sexual intercourse, which is unusual for her. So red flag, stop please. Careful about the complaint. And bowel dysfunction. So symptoms, this is some symptoms which is most common but not specific. Same back pain, unilateral or bilateral leg pain, and there is some sensory changes, bilateral weakness. This is common but not mainly specific for the Cauda Equina. But if the patient complains of saddle anesthesia, tingling, numbness, something he's not happy about his upper inner thigh or genitalia or tingling, and bladder dysfunction, sexual dysfunction, bowel dysfunction, this is you should take serious. You should take more explanation from the patient. Okay. Other things, back pain, unilateral or bilateral leg pain, it's the most common, but not most specific. So now we know the history, we know the symptoms, we are going to examine the patient. Those are saddle anesthesia this is picture. This is saddle anesthesia as you saw from S345. Here is the nerve root dermatome. innervation for the rectum, perineum, and the inner side. This is the point that the patient said, I'm not happy about this point. I'm feeling tingling. I'm feeling numbness about this area. Take serious, please. So the saddle anesthesia is very important symptoms, okay? This is the red flag. This is the red flag symptoms. First, sexual problem. When I told the patient we may complain that he have some sexual problem, impotence, you should ask the patient about what is the mainly you are not happy about. Maybe inability to achieve an erection or ejaculation. Okay, maybe loss of sensation during intercourse. This is, I told one of the patients, she's a lady, she came with the main, this is the only complaint. So just only what about impotence or no? No, you take about if he complain from some sexual problem, take it in detail. This is a red flag. So inability to achieve an erection or ejaculation, loss of sensation during intercourse, or loss of clitoral sensation. This is for the lady. Okay, this is important. Another red flag is the bladder dysfunction. He can tell inability to urinate or difficult to initiate the urination, loss of sensation during urination, or inability to stop or control the urine, loss of the full bowel sensation. This is examples that might the patient come. Saddle anesthesia, we told loss of feeling between the legs, numbness or tingling around the back passage and or genitalia, inability to feel. This is important. You can ask the patient. He will tell you, I am unable to feel the toilet paper when wiping. It's very important also. Bowel disturbantion, maybe inability to stop bowel movement, constipation, loss of sensation when passing bowel motion. So the red flag here, please take it. Very important. This is the very important and the specific things to the Cauda Equina syndrome. All of us or a member of family have back pain, but when you should stop and take it serious. If you have one of this sexual problem, bladder disturbance, saddle anesthesia, bowel disturbance, at these times you should take it carefully. It's very important as misdiagnosis of the Cauda Equina will lead to a very serious complication. Very serious. So red flag here again and again, sexual problem, bladder dysfunction, bowel disturbance, and saddle anesthesia. Another thing that we told is back pain, sciatica, leg weakness. It's common, but not more specific to the Cauda Equina. So we are going to examine now. We take the history, we know the symptoms, and we ask about the red flag signs, and you are going to examine. We're going by inspection, palpation, and neurological examination as usual for any patient. Inspection, you might see the patient distressed by pain due to low back pain. He can lie in the bed. I cannot move. I'm in pain, much pain. I cannot move. Like that is in pain by inspection. Palpation, you can see tenderness in the lower back also. And you can palpate the bladder, which is, there is urine retention. You can see this tension of the bladder, and by percussion, you can see there is a dullness in percussion. You are going after that for neurological examination. You can see bilateral or unilateral lower extremity weakness. Maybe during the examination, you should examine the anal tone, which one is the most important examination in the patient you suspect Cauda Equina syndrome, as there is a reduce in the rectal tone. Ask the patient to cough, make PR examination. There is no contraction at the anal tone. This is a red flag sign when you examine. The patient might have Cauda Equina syndrome. Sensation, reduced or absent sensation to pinprick in the perianal region. This is the perianal sensation, very important during the examination. As we told, saddle anesthesia from S3 to 4. This is low sensation. If you can make examination around this area, he will not feel anything. He lost his perianal sensation. Okay, so bilateral or unilateral low extremity sensory disturbance can happen with any back pain. Also, you can examine the reflexes, decrease or lower extremity reflexes. And there is some test you can examine. This is absence of the bulbocavernous reflex, squeezing of the glans penis or squeezing of the genitalia lead to contraction at the anal tone. This is, you can see in the Cauda Equina, this is absent. Maybe absent of the anal wink test that you can pinprick around the anal area. There is a contraction should be in the anal tone. You can, this is, can be absent. So symptoms, as you as we during the examination, you can examine any back pain. You can see weakness, if any dermatome or like any myotome, sorry, between lumbar 1 weakness, lumbar 2, lumbar 3. As you can see sensation change, but most specific is the anal tone. Very important. You will see reduced anal tone in a Cauda Equina syndrome. You can see reduced perianal sensation in the Cauda Equina syndrome. Very important to examine anal tone and perianal sensation. And also you can see the bulbocavernous reflex and anal wink test. Here is the anal wink test. As you see, pinprick, here should be contraction here at the anal tone. Here, bulbocavernous reflex, you can squeeze of the genitalia. As you see, there is contraction at the anal tone. This may be absent in the Cauda Equina syndrome. Okay, so we are going to investigation now. So I took the history of the patient, I know the symptoms, and I examined him. There is no anal tone, reduction of the anal tone, and there is perianal sensation lost. I'm very careful now, the patient might have the Cauda Equina syndrome. What you will do, you will request some investigation. What's the investigation? First investigation at the orthopedic or spine, we are requesting X-ray. Sometimes you can request the X-ray. It will help you. It's a little helping in this case if you think there is a Cauda Equina syndrome. However, it can help you if you think the patient has trauma and the cause of the Cauda Equina syndrome is fracture. So the X-ray can show you the fracture. The X-ray can show also some spondylolisthesis with some dislocation between the vertebrae. This is X-ray can let you know these things. But if the cause is a disc herniation or disc prolapse, the X-ray finding will not support you, will not help you more, because the X-ray you cannot see lumbar disc herniation in the X-ray. However, you can see some muscle spasm. Okay, but you can see, as I told, burst fracture or spondylolisthesis. The X-ray will not be helpful more. As we see here, for example, X-ray, in this image we can see spondylolisthesis, which is forward hair displacement of the lumbar 5 hair over sacral 1. You can see here fracture here, breast fracture. As you see here, the fracture is here is occupy the canal, is compress the nerves. This is some examples what the X-ray may show you. Sometimes the patient who came, you don't think it's the Cauda Equina and requested X-ray for back pain. You can find these things. It's make alarming for you. Please, this is maybe something. So take it serious. So MRI. So we told about the X-ray. We'll go to the MRI. MRI, it is the most sensitive imaging for the Cauda Equina syndrome. It's the study of the choice of your clinical examination and symptoms of the patient, history of the patient going with the Cauda Equina. So you should request MRI. And it's very important to request MRI as urgent as you can. It ideally should be done within 1 to 2 hours of the presentation to the emergency department. It's ideal, but not happen to be honest, but ideal to present in 1 to 2 hours of presentation to you. Any finding, we told this space occupying lesion. So you can find central disc herniation with complete spinal canal stenosis or obliteration of the canal, maybe presence of spinal canal stenosis. You can see hematoma, blood collection, press the nerve roots, you can see abscess, you can see whatever with space occupying lesion. This is the investigation of the choice is MRI. Okay, as we see here, this is MRI. As we see, big disc prolapse herniation which compress all the nerve roots. You can see here is fine nerve roots complete here compressed between lumbar 4 and lumbar 5, as we can see here. Is MRI. So if MRI, sometimes some patient we cannot do MRI. The patient maybe have pacemaker, maybe he has implant done before, which cannot do MRI. So there is an investigation called CT myelography. What we can find this one, we can see the space occupying lesion. We can see complete blockage of the contrast. There is some lesion here. This is if we cannot do the MRI. There is some studies. We can do blood. As we know, there is some causes of the Cauda Equina syndrome as infection, abscess, or maybe malignancy, metastasis. We can request some bloods, CBC, ESR, CRP for infection profile. One of the most important studies which required for Cauda Equina is the urodynamic studies. This can be done at emergency department, at any department. This is called the pre and post urinary bladder voidal scan. I make ultrasound scan for the bladder to see the residual volume. If it's normal, the residual volume is less than 50 to 100 millimeter after voiding. We can do measuring by ultrasound scan for the bladder. If the post-voidal residual volume is less than 200, mostly 97% the patient has no Cauda Equina syndrome. So some protocol in some trusts, he's going to do this is urodynamic studies or pre or post-voidal scan. He said post-voidal scan less than 200, the patient mostly not have Cauda Equina syndrome. This is very important to aware about this one. As we know, the bladder function is one of the red flag signs, and this is compression of the nerve roots of supplying the bladder may make this urine retention. So most of the cases which have Cauda Equina syndrome, they have urinary problem or urinary bladder problem. So we will do the pre and post-voidal scan. If the post-voidal residual volume is less than 200, mostly about 97%, the patient has no Cauda Equina syndrome. Okay, so we spoke about the X-ray, then MRI, which is the investigation of the choice in our trust. The investigation of the choice is the MRI. Clinical examination, please, if you doubt, go to MRI. This is a highly urgent case. Okay, so X-ray, MRI, lab, pre-voidal and post-voidal scan can be done in 2 or 3 minutes. So it's important also to give you a picture about what you are doing. Okay. So treatment for this condition is operation, surgical decompression. No chance for conservative treatment in Cauda Equina syndrome. Once you diagnose, it's very important to treat this patient by surgical decompression. What is the indication? This is the clinical symptoms of the Cauda Equina syndrome. With imaging supports the diagnosis. Time is very important. Time is very important. Surgery should be done within 24 hours or maximum 48 hours. You see how the urgent is the diagnosis is very important to diagnose. Okay, so surgery should be done within 24 hours or 48 hours as a maximum. Okay, what's the surgery? We will not go furthermore in the surgery, but if this patient is young, it's very simple. There is a compression. I should take the compression out and I should decompress. So if the patient is young, we can make microdiscotomy. If disc herniation is the cause, I make microdiscotomy. If the patient is quite old, I can make laminectomy, which is decompress. If there is the condition is caused by spondylolisthesis, which is some displacement of the spine, I am going to reduce the spine its place and I'm going to do fusion to avoid the displacement again. So mainly surgery. If young, I make microdiscotomy. If a little bit old, I make laminectomy. If the patient have some spondylolisthesis, laminectomy and diffusion. It's the surgery to be known as like that. So we can treat the cause. If there is a collection of hematoma, we'll drain it. If there is abscess, we'll drain it according to the etiology we know from before. Okay. What is the outcome of this? Studies show improvement in the bowel and the bladder function, motor sensory deficit when decompression happen within 48 hours. After 48 hours, it's quite dangerous. Residual bladder deficit may be persist and will inform the patient, may be persist even after successful decompression in time. Motor recovery and motor weakness will take about 1 year post-op. Bladder function may continue to improve over 16 months post-surgery. Prognosis, natural history, delay in diagnosis management can lead to lifelong impairment. What's lifelong impairment? As progressive weakness of the lower extremities without surgery, progressive loss of bowel and the bladder function without surgery. I have seen one case last month. She came with loss of hair, urinary bladder tune. She is in catheter, and about 6 months later, she came with the same patient with loss of hair, bowel control at all. So it's very important for early diagnosis. This was neglected case, not diagnosis before, and continue as a chronic Cauda equina and like that. A prognosis, presence of the saddle anesthesia from start. If the patient has saddle anesthesia, bladder dysfunction, it's usually associated with the worst outcome. Surgery decompression after 48 hours is usually worst outcome. As we tell, this is the golden hours is first 24 hours, but you can do until 48 hours. Summary. Cauda equina syndrome caused by severe compression of the nerve roots in the cecal sac of the lumbar spine, most commonly due to the lumbar disc herniation between lumbar 4 and lumbar 5. Early diagnosis is critical. How I diagnose? History, very important. Symptoms, very important. Both red flag signs, which is sexual and bladder, bowel, saddle anesthesia, put on your mind when examine any patient complaining from back pain. Very important to pick this, please. Very, very important. If you see this red flag sign and examine low anal tone reduced and perianal reduced perianal sensation, request urgent MRI, request urodynamic studies, which is pre and post voidal scan. It's very important. Now you diagnose, please refer the patient as soon as you can to spinal team for decompression. Thank you. That's all.
Yeah. Thank you, Dr. Abdallah, for this very good presentation. I want to open the discussion if anyone wants to ask, but before this, I want to add very brief comments, and please correct me if I'm wrong with any point of them. My first point to add here is that although Cauda equina syndrome is primarily something neurosurgical or orthopedic, but it is very important to know from the medical point of view and from the intensive care point of view as well. If left untreated, or even if delayed treatment, or even before diagnosis itself, Cauda equina syndrome can present with overflow incontinence. But before the patient gets an overflow, it may lead to reflux nephropathy, and patient presents with acute kidney injury. Or if the patient is already a chronic kidney patient, he may lose some of his residual kidney function. So it may hasten the deterioration of a chronic kidney patient, or it may lead to acute kidney injury of someone who is not a kidney patient. So it is very important, even from the medical point of view, not only from the orthopedic and neurosurgical point of view.
Yes, I agree with you 100%. You are right, 100%. And this cases, as you see, we sometimes are not taken as serious in the medical world, especially. I have faced this point of the problem in the medical world. Says patient here is already have some infection or some urinary tract infection. He's in urine retention. I have seen this one. Please, you are in hospital. If you doubt 1% that the patient might have this, if have this red flag signs, and 1% you suspect this is a Cauda equina, go for it. Do MRI for the patient and relieve your all thoughts and thinking, because if the patient has Cauda equina and the past 48 hours, there is, I saw 2 patients here. Really, it's a very bad thing, the patient to have some incontinence continuous for the urine or some bowel uncontrolled. It's not an easy for the patient even. So it's simple to do urodynamic studies. If you even MRI is not ready now, urodynamic studies, the pre-voidal and the post-voidal, anyone can do by ultrasound scan to see how much of the urine inside the bladder. Make it simple, less than 200, 97% the patient is not have Cauda equina, and you, if more than 200, request MRI, make the early diagnosis. This is very important to pick up these cases.
Yes, of course, I totally agree with all this. I also want to add something else, which it's very famous for us in the ICU, that some patients who are agitated or having delirium or are confused, or what we call sometimes the ITU psychosis, these patients may be constipated, whether like stool constipation, or they are like they are in urine constipation. So these patients may be actually having Cauda Equina syndrome, and they are just agitated, and they're not aware of any other symptoms like back pain or saddle anesthesia or something. So this is also something to consider in any patient with delirium or confusion. Inpatient, you should at least check the suprapubic area to see if there is a palpable bladder or not, at least.
Yeah, I agree. Check anal tone as we there, check perianal sensation will help you more. If everything is fine, you are happy, okay, this is just constipation for you. But if you think this low anal tone, reduced anal tone, perianal sensation is lost, so it's important to work in this case. Okay.
Yes. My last comment, and I want you to correct me if this is wrong. I think I have read this information that not like the percentage of patients who have saddle anesthesia on examination, like there are much fewer patients who complain of saddle paresthesia. So if you ask the patient, do you have any numbness or tingling in your saddle area, he will say no, but there will be anesthesia on examination. So history alone will not be sufficient here.
Yeah, okay, I agree with you. I don't have the information, to be honest. I didn't read it, but yes, you can examine, as I told, I am based on your examination, the perianal sensation, break sensation I have told about when I'm giving this topic. So I think, yes, you are right. And always the condition, to be honest, also as the first epidemiology we told, is very rare condition, 1.5 to 3 per million. But I have seen here in the country many patients of the Cauda Equina syndrome in my on-call duties. Really, I'm surprised. Working before Saudi Arabia, I haven't seen one case, but here I have seen many. Every duty for me, there is some suspicion, and there is some cases in my duty. About 2 months on call, I have referred 2 cases with Cauda Equina syndrome confirmed by MRI for spinal team for urgent decompression. This is case here highly serious, and all the team, any team, ambulance, all know about it. Spinal teams, they are waiting the case. So I don't know this country. I saw many cases here, confirmed diagnosis with a Cauda Equina syndrome in all the ages. So I don't know why, but I have seen this patient. So to aware about this point is very important, to know at least some, to know. But to see what's the symptoms, examine what is the investigation, to be aware about the case, it's important to us in this country. I have seen, really, I'm not a spinal surgeon, but I cover these cases because we don't have spinal surgeon here. When I diagnose, I just send the case for spinal team. This is highly urgent for them, for the consultants there, to do the surgery as early as can to save, because as you know, as we told, after 48 hours, this is no much improvement may be happen to the patient. The progress will not become good. Surgery will not help the patient more as done within 48 hours or 24 hours.
I have one question for Abdallah, please. What I can remember is Cauda Equina syndrome was always linked with the conus medullaris syndrome. If it's possible, can we highlight the main differences between those?
Yeah. You see, this is, we told what is the anatomy of the conus medullaris. The conus medullaris is the end of the spinal cord at the level of lumbar 1, lumbar 2. Okay, so pressure above lumbar 1, lumbar 2 will pressure over the spinal cord itself. Mostly, you will not see urinary symptoms, sexual symptoms, or this is the saddle anesthesia, because it's a compression mainly. After this one, you will compress sacral 2 nerve roots, sacral 3, sacral 4. This is the nerve roots. So this is compression above the lumbar 1 will conus medullaris. At the end of the lumbar 1, lumbar 2, this is conus medullaris symptom. Below this one, which is the Cauda Equina syndrome, this is the condition which is highly urgent to be decompressed in 24 to 48 hours. Okay, the other is not so urgent to decompress as this one, as the nerve roots in the spinal canal, this area is very sensitive, very sensitive. Any compression here will maybe lead to long-standing problem. With long-standing weakness, will long-standing also lose his function of the bowel of the bladder.
You mean the urinary control and the bowel continence and sexual?
Yeah. You see, above this
sensation
level,
function.
the nerve roots can be covered by epineurum or endonerium, and but in this only the nerve is covered one layer only with endonerium. Any pressure hair, any compressed hair will make a lot of manifestation, more damage. That's why.
Thank you.
Thank you so much.